PO4 over H2PO4 is the main urinary buffer. Its ratio 1 uh, ratio 10 normally regulates the pH of urine. If acidosis, more phosphate is excreted as NaH2PO4, eliminating excess H plus ions. Along with it, this increased excretion of H plus ions in urine it raises the blood pH back to normal. The amount of H plus ions in combination with PO4 as H2PO4 excreted in urine is known as titrable acid. In alkalosis, process will be reverted. Formation of ammonia. Acidosis increases the formation of ammonia, which buffers H plus ions and forms NH4. Ammonium. This ammonium is then excreted in urine in the form of NH4Cl, ammonium chloride. Alkalosis decreases the formation of NH3, excretion of H plus ions as free acid, keto acids. Ketoacidosis. It is the acidosis, less pH, caused by abnormal accumulation of ketone bodies in blood, mainly seen in uncontrolled diabetes mellitus and starvation. Ketone bodies, these are three ketone bodies which are acetone, acetate, beta hydroxy beta. These are formed from the fatty acid metabolism. Acetone is a volatile acid and therefore does not appear in urine. It is mainly excreted in breath. Acetate and beta hydroxybutyric acid are fixed acid and are filtered by glomeruli and excreted in urine in large amounts. The anion of these ketone bodies combine with H plus ions and form their corresponding keto acid. These acids are then excreted in urine along with H plus ions. This excretion of H plus ions reverses the acidosis. Sodium potassium exchange with H plus ions. In acidosis, more H plus ions are available in the distal tubules to exchange for sodium ions. Thus, potassium ions are retained in blood. Therefore, in acidosis, potassium level increases, which may lead to hyperkalemia, increased potassium in blood. In alkalosis, H plus ions are less in the distal tubules. Therefore, there is no exchange of H plus ions with sodium, resulting in greater loss of potassium ions in the urine level. Therefore, in alkalosis, potassium level decreases, which may lead to hypokalemia, decreased potassium in blood. Metabolic and respiratory acidosis. Acidosis can be due to metabolic or respiratory abnormalities. In order to save life and to provide proper treatment, it is very important to know the type of acidosis, metabolic or respiratory. Type of acidosis can be assessed by looking at the carbon dioxide acid in arterial ABG, arterial blood gas analysis. Normal PCO2 is 35 to 45 mmHg. In acidosis, pH will be low, less than 7.4. To determine between metabolic and respiratory acidosis, look at the PCO2 in ABG. If PCO2 is less than 40 mmHg, decreased carbon dioxide and in decreased pH, it is metabolic acidosis with compensations. If PCO2 is greater than 40 mmHg, increased carbon dioxide and decreased pH, it is respiratory acidosis. Metabolic acidosis. Primary defect, decreased arterial HCO3, decreased blood pH, acidosis. It is either due to the excessive accumulations of strong acid in blood or increased loss of bases from blood. The accumulation of strong acid may be endogenous ketoacidosis from lipid metabolism as seen in uncontrolled diabetes mellitus or exogenous drug poisoning. Bicarbonate loss may occur via GIT, diarrhea, or via kidney renal tubular acidosis. Excessive accumulation of acid results in increased H plus ions in blood acidemia. Most of the bicarbonate is used up in buffering the H plus ions and as a result HCO3 level falls, decrease HCO3 in blood. The carbon dioxide produced during the buffering is excreted uh, through breathing, respiratory compensation. Depending on the anion gap, there are two types of metabolic acidosis: normal anion gap metabolic acidosis and increased anion gap metabolic acidosis. Anion gap. AG is the difference between primary measured cation, sodium and potassium, and primary measured anions, chloride and HCO3. It represents the concentration of all the unmeasured anion in the plasma. Negatively charged protein. Major unmeasured anions are calculated by AG. The acid anion lactate acetostate produced during metabolic acidosis are not measured by the laboratory routinely. ICO3 measured anion buffers the H plus of these acids and becomes low in blood. The net effect will be decreased concentration of measured anion HCO3 and increase in unmeasured anion, the acid anion, which increases the Ag. Ag is calculated by sodium and chloride plus HCO3. Normal Ag is A to A 16 millimole per liter. Thank you very much.